Good afternoon. Probably, yes, we had a very topic given is very, very vast as you begin as a tiny newborn and you reach adulthood. What are your future outcomes if we have to see to do justice in just 30 or 35 minutes is really a marathon task. Along with me, I have 4 expert neonatologists from Gujarat. We're just waiting for Dr. Mohit to join us, probably somewhere. He is in the lunch area, probably. Just somebody could. Yeah, we would start. So I'll have to just say a thing. We have Dr. Prakash Vaghela. He is a practicing neonatologist at Bhavnagar. Then Dhyey Pandya, a practicing neonatologist and affiliated to Sassoon Hospital, Pune. And I think he's son of the soil, Bhavnagar boy. And then I have another young budding neonatologist, Dr. Sandeep Tilwani, who is assistant professor of neonatology at Adani Institute of Medical Sciences, Bhuj. Okay, without wasting much of time, let's go ahead. Just to give you a brief background, preterm births occurring before 37 weeks or the birth weights that we all are aware about. But just what I wanted to tell you is burden is quite significant for low and middle income group countries like ours. Okay, actually the high income or upper strata countries have much lower incidence of preterm birth, while Southeast Asian countries have been leading in it with an incidence of rising above 15, 15.5, with Bangladesh rating as the highest at 16.2. So all of us with our population and with an increased incidence of prematurity, our burden, and with advancing care in neonatology at every sector, public sector as well as private sector, we have started salvaging them. Salvaging them alone is not going to help because our future population is going to be these babies. So what we need to do and how could we improve it to have better future outcome is what we are trying to discuss over the next 30 minutes. Next. Okay, look at this. The series that Lancet came around with small and vulnerable newborns. 55% of them, half of them, neonatal deaths are contributed by them. Babies born with these vulnerabilities of being small and vulnerable are at increased risk of multiple and adverse health conditions throughout their lifespan. So the care doesn't end at the discharge from NICU or even from community, because there are stable SGA small babies also who are growing up. Not even at 2 years, as what we call it as age where the baby would have, otherwise one would have known as the corrected gestational age. It goes up to adulthood is what we really wanted to emphasize. Next. Just I'll not go into details of it, but look at it. These are our government of Gujarat, SNCU data, where look at the number of babies who are going to be preterm and low birth weight and very low birth weight babies. Next. We'll start with Dr. Dhyey. What is intact survival in our current understanding? And what most of our long-term studies have been looking at what age?
Yes, ma'am. So as ma'am rightly mentioned, neonatal care has improved drastically within last few years, both in private sector as well as public sector. We are surviving more and more extreme preterm, extreme low birth weight babies. So now the goal of neonatal care should not be just the survival, but survival without any major neurodevelopmental delays. And that is also specifically at corrected age of 2 years that most of us look at. So many a times we see social media posts, a 600 grammer baby stayed in NICU for 60 days, USG brain being done, normal ROP being done, and we write, yes, intact survival. But that is just half of the story. This neonate should be followed up in neurodevelopmental OPDs, and we would call it an intact survival only when the newborn does not have any major disability, that is no any motor delays, cognition being intact, no neurosensory delays like that is blindness and deafness, and even normal neuro behavior. If it is documented, then only we will call it in intake survival. So regarding all the follow-up studies also, they target now the same. We just not look at survival, but we look at no neurodevelopmental disabilities at around 2 years. And all the studies need to have definite outcomes, but as practitioners or healthcare providers, we should look beyond 2 years. That is because certain soft disabilities like learning disabilities, like neurobehavioral disorders, ADHD, ASD, other cognitive issues will appear much later. So these newborns, all our preterms, require our support beyond NICU, beyond 2 years, up to adolescents and up to adulthood.
Okay. Thank you, Dhyey. So what is my upcoming generation of pediatricians, because I expected quite a few postgraduates here, as well as practicing pediatrician, that you're going to always, whenever you are seeing a patient, look at their gestation and birth size, because you are going to have a long-term continuum where you will have to look at many things. Coming to Dr. Mohit, beyond survival, what, as they are told, it's not only the neurodevelopment. All these babies have different degrees of respiratory and cardiovascular morbidities they have gone through. They are born preterm, they are born early, they are born small. They have received invasive, non-invasive ventilation, surfactant, caffeine, many things. What is their long-term pulmonary outcome and the cardiac outcome? Yes.
So, thank you, madam. Thanks to the organizers for inviting us. So this is something which is, we as a neonatologist, we have very short-sightedness for this. So what normally we used to believe that in our practice, once the baby is out of NICU, of respiratory issues, gaining weight, okay, we will just hold here, madam.
Okay.
So yeah, so thank you. So, so gaining weight, doing well, then anything happens afterward, then I used to tell my PICU colleagues, our work is done, this is now yours. So we are done. For us, the survival is 92%, 95%. And 10 years back, we had discharged tiniest surviving twins for India, 503, 530 grams. And we published, put in the newspaper only when they were 5 years old. And I thought, now 5 years old, they will do very well. So I stopped even bothering about them. So, but at that point of time, much of the literature, publications were not there. And this, in this slide, you can see there is a lot of, there is a lot of load for the preterms overall in the world. It is, and India is now a factory for the preterms in the world. And now we have to think, because it is going to hit us after 20, 30 years. Madam, next slide, madam, please.
Next.
So that's why we call it a two-hit developmental model. Why there is a double hit? Why? Because cardiac is being exposed to many things during neonatal period. And I used to believe I have maintained ventilation, I have maintained blood pressures, treated sepsis, given surfactant, given steroids, things are done. But what we did in NICU is going to hit that baby later on. And that is why double hit means then it is hitting the respiratory system also. And next, please.
Next.
So this is a very nice manned mapping to explain this. So in this, very nicely you can see the issues are pulmonary morbidities. In that you can see a lot of things for which we have been treating them. But later on, we always try to diagnose them later on in their childhood as the asthma babies. But basically, now the terminology has come, it is premature associated lung disease. That is morphologically different from what we are treating in them as asthma. Altogether different entity. Okay, and then obstructive and all those morbidities are there. Cardiac and vascular morbidities, they again, I treat PDA, I have treated BPD, I have treated a lot of things. But later on, because of the low volume in their heart and their vascular remodeling, we have exposed them, and now the data is showing all the preterm babies, more they are preterm, 53% higher rate of ischemic heart disease after 40 years of age. So that's why we have to monitor them echocardiographically, which is sometimes different. But the easiest thing to do is the blood pressure monitoring. My daughter, she is here, she is doing MBBS in Bhavnagar Medical College, and I was telling her, now after this session, I'm going to make a protocol for my unit that till 16 years of age, we will be monitoring their blood pressures. And it is being documented in the literature. And we have to do it with appropriate cuff size and everything, but it is the easiest thing to do. Okay, and then this, there is a table, we will be showing that table also. And then if we just see this and we go ahead with the outpatient, what all we think we need. So this is the one thing, the blood pressures when you take. Just after discharge and follow them every 15 days till first 3 months, every month till 6 months, every 2 months till 1 year, and then every year after 3 years of age. Don't let them go. Spirometry has to be done. Pediatric cardiology, if you have issues with oxygenation or repeated respiratory issues, get the heart check done because they had a brunt in their premature period. So we never thought that this is gone. The only thing that was there in our head was Barker's hypothesis. That is now being nullified. Like there are so many other things instead of Barker's hypothesis. And then, yeah, so as adulthood is increased, you see a lot of COPDs and all this trajectory, they are very highly prone for that. Next slide, madam, please. So this is what I was telling you, prematurity associated lung disease. This is the terminology which has come up in the last 2 to 3 years in the literature. And the other terminology which has come up in the literature, which I am seeing now is no smoking and vaping. The VAP has now come with smoking. So this is something which has changed over the years. Next slide. So this is the blood pressure thing, when to do and when we have to look for that. Next slide, madam, please. So we have to monitor their blood pressures, do the spirometries, lung function tests, at least at 5 to 6, preschool or school age, to have a monitoring, proper monitoring with blood pressure, echocardiography, and spirometry, pulmonary function tests.
Thank you, Dr. Mohit, for in a simplified manner to explain. Because now the high-risk follow-up is going to continue beyond adulthood. It is what they would have to, it is a lifelong thing where the prematurity and small vulnerable newborn, with depending on the amount of insult, but always don't overlook that this baby did not stay in NICU, that's why he's safe. No, he does come with some epigenetically also modified factors. So I think as a pediatrician, our role in simple, we thought well baby clinic. No, we'll have to have now preterm children coming to our clinic and look at them with this. Coming to the next. Yeah, you could just cover.
When in cardiologists, now they should have in high risk, if they have NICU discharge in their hand, so that may place them in a high risk group for cardiologists. So this is one of the factor, high risk factor.
So every system is going to be with high risk. Okay, we were just trying to cover some of the major ones, but remember that when you are looking at a preemie or a small vulnerable newborn. So yes, beyond survival means, as Dr. Mohit has clearly put it, lifelong cardiopulmonary surveillance. Okay, he's already defined others, prematurity associated lung disease, the protocol for blood pressure monitoring, as well as pulmonary hypertension and other things which would be coming, which is to be looked out. So probably we really need to make some more protocols for each of our babies now further. Next. Okay, coming to Dr. Prakash. Now we were looking at respiratory and cardiopulmonary, but how does this chronic neonatal diseases compromise the long-term physiological impacts? Because a full-term baby with no morbidity, what he ends up having as an intact physiology, and clinical paradox which we have with our SAM children and even our babies with FGR and IGR, early aggressive nutrition for this SVN, do create a metabolic issue. So what does the current evidence tell us and indicate what is the risk of metabolic syndrome in these babies for obesity, insulin resistance and lipid disorders? Because probably India is becoming the hub for all of them.
Yes, good afternoon, the respected ma'ams, chairpersons and the delegates. We know the survival of the extremely low birth weight baby and the very low birth weight baby is increasing. But whenever the gestational age is when decrease, these chances of the chronic disease, like chronic disease like the bronchopulmonary dysplasia, IVH, periventricular leukomalacia, this retinopathy of prematurity, and the necrotizing enterocolitis. This common chronic disease, especially in the ELBW or VLBW, like the infection, hypoxia, acidosis, this will not only damage the structure, but this will damage their function, even their genetics also. So they have the lifelong impactness is there. If we think I have discharged the 27, 26, 24 weeks of the baby, and this baby had some chronic neonatological problems, like if this baby had the periventricular leukomalacia or IVH grade 1, 2, so this can lead to the lifelong lability of the cerebral palsy, learning skill difficulty, and same the other issue as the Mohit has mentioned about the cardiorespiratory issue. If this baby, I am happy that I have survived this baby from necrotizing enterocolitis. But necrotizing enterocolitis in later of the life, this can lead to the growth retardation and some metabolic issue is there. So prevention of the chronic disease, especially in the extremely low birth weight baby, by the good antenatal care, with delivery room care and the good NICU care. This is the main aims. Second, if because it will, some IUGR baby, they have, and the SGA baby have the more risk for developing these types of baby. And they have the increased the metabolic issue, like the hyperlipidemia, type 2 diabetes mellitus, hypertension, etc.
And just one more thing, that's why growth monitoring will have to be very specifically looked at with their growth charts. Okay, coming to...
not just only we have to monitor the weights, just we strongly say that mother own milk is the only, not the high calorie formula and that's. Only not we have to monitor the linear growth of the baby.
Linear growth and head growth are the two more important markers that you would do it in the first 2 years. But later also the growth charting, or unless until you are seeing a short stature or you are seeing something, many times it's missed. So it really definitely requires more intense monitoring till adulthood. Dr. Dhyey, how do they grow in their physical stature? The impact of FGR. Nowadays, instead of IUGR, we call it as fetal growth restriction. And the extrauterine growth restriction, which is very, very common with our NICU graduates.
Yes, ma'am.
Do they catch up?
Yes, ma'am. So, growth of preterm neonates depends on multiple factors. First of all, the genetic. What is the genetic potential? Then, birth weight and gestation of the baby. What was the intrauterine milieu or intrauterine nutrition status, as well as very important postnatal nutrition. And of course the neonatal morbidities, as Dr. Prakash has rightly mentioned, all these play a role on follow-up growth of preterm neonates. Now as we all know, a typical preterm AGA neonate who does not have any major morbidities will have a growth curve in form of initial weight loss because of extracellular fluid contraction. Then they will typically grow with 15 to 20 gram per kg per day. The weight catch-up happens between 3 to 6 months and the height catch-up appear later. Most of us target that the neonate should grow according to the curvature, how the fetus was growing in utero. However, there are catches associated with it. As ma'am rightly mentioned, we should all plot the growth of the neonates. What we usually do is less than 30-week neonate, we follow Fenton's, and more than 30 weeks, we follow intergrowth 21 growth charts. It is important to take advantage of all the vaccination visits. It hardly takes 2 to 3 minutes to plot head circumference, length and weight of the baby on the growth charts. They, I think, continue up to 50 weeks for Fenton's and up to 64 weeks for intergrowth, and then we can follow the WHO growth charts. Here it is very much important that we just not look at the growth. We all are very much happy, 100, 200 gram of weight gain within 1 week. Yes, you come up again, but as sir rightly mentioned, the quality of growth is important. The linear growth, which suggests the fat-free mass, because that growth protects them for future metabolic risk factors. So it is important that they grow likewise in head circumference and length as well, apart from their weight gain. Coming to the next question, the growth of SG neonates is a bit different from AGA, as we know that they tend to have the catch-up growth. Now, when we say catch-up, what is catch-up? When they match their medians for weight and height, we call that the catch-up has happened. Typically for weight, it happens by around 6 months. For height, it happens in and around 2 years. Most of the neonates, that is 70 to 80% of FGR neonates or SGA neonates, do catch up. Those who are late FGR, that is the fetal growth restriction has started after 32 weeks of gestation, or neonates who are what we used to call asymmetric IUGRs, that is head circumference was preserved, only the weight was less. They typically had risk factors in form of maternal PIH or maternal placental insufficiencies. They tend to catch up well. Those neonates who had early insults, that is early FGRs, 10 to 15% of them do not grow well. They remain stunted. These neonates, if you catch them early, will benefit with therapies like growth hormone. And to remind you, growth hormone just not helps in height catch-up, but it will also sometimes improve their overall metabolic health. So it is something important. Regarding catch-up of, as sir rightly mentioned, regarding catch-up of SGO units, so how to provide them nutrition is a question, because as we all know, good catch-up growth is important for their brain. But it is always the brain versus heart theory. It is not those neonates who catch up very fast. They are more prone for ischemic heart disease and metabolic disease later on. So what we do is, yes, nutrition is important, proper breastfeeding, proper breast milk, along with fortification. Let them have good catch-up, but the moment they start crossing the centiles on growth charts, at that moment we should be cautious. We should not them allow to cross the centiles so that they do not become obese and at risk for metabolic disease later on.
Yes, it's one of the, this all has lot of details to be covered. With shortage of time, I'm going to cut back on it. As I told you in the beginning itself, that every system, there are a lot of minute things which really need to be looked at. Dr. Sandeep, now coming to one of the major things. Till now, probably we were looking at this only more at intact survival, and again at intact survival till 5 years. Probably the recent, some of the data which has come, which has been eye-opening. So what is the long-term outcome of this? Various studies have shown us in neuromotor, cognitive, psychiatric disorders, mental and emotional health issues, sensory impairments. Even now they have gone in adulthood, their workplace adjustments, their tolerance to that, when everything else looked to normal to us in school days. School dropouts, college dropouts, everything has been studied in them. So let's look at it.
Good afternoon, everyone. As ma'am rightly pointed out, it is very difficult to summarize the entire long-term impact in 30 minutes or 40 minutes. Adding to it, if you look about the research related to the long-term outcomes of preterm neonates, it is very much complex. Why is it complex? Because the populations in which various studies have been done, they are diverse. The time at which certain studies have been done. So some have been done in the pre-surfactant era, some have been done in the pre-steroid era, some of them have been done in the pre-magnesium sulfate era. So different eras, different studies, and many of them have been done in the era previous to what we were doing, like delayed cord clamping. So we do not know what is the impact of those things taken together. But one thing is for sure that it is the modern medical paradox that with the improved care of the newborns, the survival rates for the smallest newborns has improved. But what remains persistent is the developmental vulnerability. So a baby who is born at 28 weeks was developmentally vulnerable 30 years before, but the child is even developmentally vulnerable today also. Coming back to the question which ma'am had specifically asked, there are two parts in which I would like to answer. So first is about the neuromotor outcome and second about the cognitive outcomes. So about the neuromotor outcomes, I will take the help of this systematic review which was published last year only, and they have looked at the risk factors for cerebral palsy in infants. So what this review has told, if you can look at it very carefully, the equivalent odds ratio at babies who are born at less than 32 weeks, they are the highest. So if a child is born at less than 32 weeks, there is 40 times higher odds that the child will develop cerebral palsy, and the odds, they subsequently decrease with progressing gestation. What does this imply? That the time spent in utero is actually the best protector against cerebral palsy. Looking at the birth weight also, if the child is born at a birth weight of less than 1.5 kg, the equivalent odds is 26.22, and if the weight is between 1.5 to 2.5, the odds decreases to 7.86. So higher the weight, the lesser are the odds of cerebral palsy. So then this is one of the other narrative reviews. So what we are, like when it comes to neuromotor outcomes, what we think is majority of the times only about cerebral palsy, but it is not only cerebral palsy. What this review shows us that like with the increasing advances in the modern neonatal care, the survival has increased and the rates of cerebral palsy have come down. But the problem is that non-cerebral palsy motor deficits, which mainly includes the developmental coordination disorders, that has gone up strikingly. So that is one of the major challenges now. Like we are not able to bring down the rates of the developmental coordination disorders. What this graph shows us is that like in all the babies who have been surviving, there is actually a difference of one standard deviation between the VLBW cohort and the very preterm cohort and the cohort that is born at term gestation. Next slide. So as I told, yeah, so these are the main motor problems we see other than cerebral palsy. They have issues with fine motor skills. They have issues with aiming, throwing, catching the ball. They have issues with gross motor balance like walking, running, jumping. All these scores are less. So when they compared preterm low birth weight babies with term babies, they were deficit in all these areas. Then coming to the cognitive aspect, so this is actually one of the, I would say, landmark umbrella reviews which was published in this year only, in March 2026. And so it has looked at the cognitive and the educational outcomes of these babies. I'll not go much into the statistics part. So what it actually showed that if a child is born preterm, there is actually a 10-point difference in IQ between a child who is born preterm and the child who is born at term gestation. So they are at, I mean, there is a 10-point difference in the IQ. Other than IQ, there are other areas where these babies would be grossly lacking, mainly the mathematical skills and reading, spelling. So these are the other areas where the child would be grossly lacking. Next slide. So this risk is again correlates well with the degree of prematurity. So if a child is born extreme preterm, the deficit in IQ and deficit in mathematics is more severe as compared to a child who is born at moderate and late preterm. Next slide. And similarly, it correlates well with the birth weight. So if a child is born at a weight less than 1 kg, the deficit in IQ and mathematics is more severe as compared to a child who is born between 1.5 to 2.5 kgs. Next. So one more important finding which this umbrella review has showed us, that these deficits which we are seeing in the early childhood, many of these deficits, they actually persist into adulthood as well. So many of these babies who were followed up till the age of 18 years, they found that over a period of time, their ability to cope up with mathematical skills improves, their ability to read may improve, but the general IQ as such remains lower as compared to a term newborn. And so these children are, next slide. So these children are at a higher risk. The odds of requiring special educational support is actually 2.85 times higher than that of a child who is born at full term gestation. Next.
What does Indian data indicate?
So in India, the proper long-term data is bit lacking. Only original long-term study I could find was from Pune low birth weight study, which was done in KM Pune from Chaudhary Madam and group. They have studied neonates actually from pre-ventilation era up to 18 years of age. What they found was similar kind of what sir has told, that the overall general IQ remains low in low birth weight neonates compared to appropriate growth weight neonates. Although in the normal range it is lower, and the worst are preterm SGA. So it is worse to be born early, but with low birth weight. So typically
Growth restricted.
Yeah. So what I would just like 1 minute, many a times gynec people, what do? They try to prolong the pregnancy. है ना? આપણે 34 સુધી ખેંચી કાઢીએ. એ જે ખેંચી કાઢવાનું છે ને, ત્યાં આપણે આ કોટ કરી શકીએ કે these neonates who are gestation prolong કરવા કોશિશ કરીએ, but they are not growing. Two sonographies do not show any weight gain. It is better to take them out early. Not much very long-term studies I could found, but a couple of studies that I have quoted are they have motor delays, typically around 10 to 12% of all VLBW neonates. ELBW, that percentage is higher, around 30%.
Yeah.
And they should also be looked for visuomotor and language delays because they require some kind of supports.
I think what are the challenges that I was to ask Dr. Mohit, but we are short of time. But core conclusions that I would like to, at the end of this, our rapid panel discussion, that it's a lifelong continuum. Gestation and birth ties have a lifelong impact. So all of us as pediatricians, as people of adolescent medicine, will have to give an extra protocol where we would be monitoring them when they come. Yes?
Just two observations from the data that has been shown. All the preterms, they were significantly bad in mathematics.
Mathematics.
So that means they are not going to become engineers, they are all going to become doctors.
Yes.
We should be very careful. Other thing was, like, जब भी मैं काउंसलिंग करता हूँ, मैं प्रीटर्म पेरेंट्स को बोलता हूँ, फिक्र ना करो, एवरीथिंग विल बी वेल. आइंस्टाइन भी प्रीटर्म था. ये देखने के बाद लगता है आइंस्टाइन सच में प्रीटर्म था. So these are the two things I would like to say. So we have to be very cautious. That is the only thing.
Again, as earlier also told, the data is so much mixed with better and better neonatal care becoming available. Maybe we are going to improve the outcome. Definitely.
Because we did one study, madam, in growth and development. So the term babies with birth dyslexia, they were like, but the only issue was, all our studies, we included major developmental milestone issues. Now the data is leaving them.
Yes.
Because they are doing very good in that part. We are following now the minor developmental issues.
That's what, like, it's not CP. Non-CP are the problems that we have to look at. So it's a lifelong continuum. Health challenges associated with it. Probably we can have a workshop on it, doing it for 3 or 4 hours and have protocols. And it persists beyond. Earlier, the higher the risk. And all this brings an economic impact. That is something which we have to take care. So it would be to improve outcomes, proactive and longitudinal monitoring. No clinician should consider at the discharge from neonatal intensive care or your routine nurseries as cured. Long-term multidisciplinary outcome, holistic approach, looking at various things, okay? As this was already, buying extra time in utero, very important thing. Perinatal disease defense preparation, which we all are doing now. Again, proactive and protective both have to be done. Again, single course of corticosteroid, magnesium sulfate, delivery room protocol, all this have come up late now. So it's going to make an impact. Okay, avoidance zones of hypocarbia and hypercarbia. Okay, so probably the trajectory blueprint from this neonatal health event to a lifelong developmental priority. Advances in perinatal care have successfully secured the survival. Now our job is to how to bridge this gap and give them the best outcome.
इधर मैडम AI ने भी यही किया है. जो ग्रेजुएशन कैप है वो डॉक्टर के साथ ही रखा हुआ है.
So that's where the challenge is. Okay, I think I thank all my expert panelists. I know we didn't have developmental pediatrician here, but then definitely neonatologists know what we are discharging, what we are going to have tomorrow them as grown-up adults. Thank you so much. And thank the organizers for choosing this topic, because this needs now more discussion for future pediatricians. Thank you.